Welcome to the October 16th Gravity Terminology Public Call. I'm sure more folks will trickle in as we go. We're going to enter end-to-end review today. We'll talk about what that means, but we are going to be continuing our work addressing the community level domains of food access, neighborhood safety, and access to green space, moving up from the household level that we addressed early in our work to touch base on community and neighborhood level drivers and how they affect health. Next slide. We welcome all of you. Everyone's muted upon entry, but we do a fair bit of talking as we go through. So we'll raise your hand and we'll make sure that we integrate you into the conversation. All calls are recorded and recordings are always available on the Gravity Confluence. The simple, like in the meetings tab, we put everything we've ever done there. It's a very long list. When you are participating in the chat, please send things to everybody just so we can keep our consensus methods intact and have everybody see the things that are coming up. So just send chats to everybody. Next slide. We are an HL7 accelerator, and therefore, as an HL7 accelerator, we are, as HL7 is, accredited by the American National Standards Institute. So the principles of ANSI are vast, but one of them is that we have to abide by federal and state antitrust laws. And so we just make sure that we apply these both specifically and quite liberally. So please make sure to not discuss any pricing or other people's pricing or any term that might affect pricing or fees. As we do our work here, this is all about concepts and purposes and meanings regarding the work that we do. And we just make sure that it not just direct violations, but anything that might be construed as a violation is discouraged. Thank you so much. Next slide. Our agenda today, brief welcome and announcements, mostly because we're through the conference cycle. Corinne and I went all over for a little bit, so we're now kind of settled. There's some conferences upcoming, but nothing too much. We're then going to go into end-to-end review. We'll describe what that is across each of our domains: neighborhood safety, food access, and access to green space. And then we're going to close with community homework and next steps. The LOINC Social Care Document Enhancement Initiative is just a continual FYI about that work to make sure that we continue to socialize it to ensure all of your brains are thinking about possible additional LOINC document types. Next slide. Next slide. Very brief little announcements. We did not put any conferences here today. We have some conferences that we're attending locally in New York to support the waiver there, and then we're looking forward to winter 2026. So the big topics are continuing to join. My partner in the good, Corey Smith, is on the call today as the technical director in the technical workstream meetings, Wednesdays 1 to 2 p.m., where we're working on the use cases and purposes in our 3.0 update of our SDOH Clinical Care Implementation Guide. Conversations are fun, novel, interesting, unique. Please come join. And then implementation workstream, we're aiming for our next meeting, which is November 20th. What I just realized is I neglected to put an announcement here that I could have mentioned, actually two, and poor Sarah Bahal, she's trying to make sure it's thorough, and I have two late-breaking things. Number one is, as part of our next email to the Gravity Terminology Division, we'll share the letter of support, if you want to write one, for our IC10-CM submissions for toxic stress and adverse childhood experiences. Comments on the IC10-CM submission are due by November 14th, so we'll share a letter with you and a link for that. And then we did want to update you, and I think I might have said this before, but I don't know, is that we did submit to United States Core Data for Interoperability request for a data class for protective factors, the work that we did in the spring. So those are just two updates. Again, our terminology work stream is not done when we stop meeting on concepts. We have submissions to support, and that's the IC10-CM work, and we'll share that letter. And then we have policy to support, and that relates to trying to advocate for the core concepts that we all create together to be part of core data classes. And so that was part of that submission. Nothing to do on the USDDI submission. We have to wait for it to go through all of the wheels of ASTP. And likely it'll just be a level 0 concept that we can have comments on in the future. But just know that we are accountable to the work we do, and we completed those two things. And a letter of support, a draft template is coming soon on ICD. Next slide. Any questions on those things? Again, sorry to forget those two announcements, but I'm going to keep on talking about them over the course of our time. So we'll come back in a couple weeks and talk about them more. All right, next slide. I think making sure. Oh, great. Okay. So who are we? We are collaborative with the goal to develop consensus-driven data standards to support the collection, use, and exchange of data to address the social determinants of health. We're glad that you all are here. Next slide. I'm very, very grateful for our members. We have a new member. I'm grateful for CVS and the CVS family of services joining our work. Super excited. I just had a great conversation with CVS Specialty Pharmacy last week on all the ways they're using social determinants of health data in their patient care. So look forward to having them as part of the Gravity member family, and grateful for them. It's always fun to add folks who have such a wide array of services and ways they meet patients and clients. Next slide. Here we are, end-to-end review. So just as an orientation, you can see our Gravity terminology process takes a few months, right? We're very careful. We spend, the links to the biweekly Wednesday. Oh yes, we can absolutely. So we have all kinds of ways to do that. We will connect you. We both have folks who can put the link to the Zoom meeting in the chat. We have the meeting link on the Confluence that can always take you there. We have ways to sign up for listservs, but we got you on all those things. More information coming. On the so information seeking on how to join the Wednesday tech calls. We'd love to see you there. More links coming into the chat very shortly. So for the first couple of months of our work, we do a lot of just brainstorming together, and then we start to lock things down. We are, again, ANSI accredited, so we have formal processes by which we create our terminology and our concepts. And so an end-to-end review, it lasts 3 meetings, so over the course of 6 weeks. And it's all towards driving toward an efficient, necessary set of information ahead of the vote on November 20th. We're going to talk about what end-to-end review is very shortly. Next slide. Part of end-to-end review, and again, we're going to go more into the roles there, is really ensuring that we step back from just coming to meetings and we go to the Confluence, which is a little bit overwhelming, but we have this handy guide here. We download the master list, which that master list is the seed of all the work to come. It is the seed for our terminology submissions. It's the seed for our value sets that we create in VSAC. We want you to download those master lists and look at them, because our job right now in end-to-end review is the methodical review of each of the master lists for each of the domains of reference. So if you go to the Gravity Confluence, the meeting information you were just seeking, friend, is in the upcoming meeting information up here on the 3rd caret, but we're going to put it in the link very shortly. In the terminology work stream, if you drop down, you can see the domains we're addressing are always the final ones: the food access, neighborhood safety, and access to green space. The masters that we create that are things that have gone through the vetting process are always published on Tuesdays by 5 p.m. Pacific time. So our job right now is to download those masters, look at them, and everything. And we're going to talk about the method for end-to-end review, submitting comments very shortly. It's much more formal than just coming to the meetings, but that is the set of information we need to make sure is good and fit for purpose. And you can take the master lists and you can bring them to your constituents, and you can bring them to your people, and you can develop consensus comments, and you can bring them back. But the master lists really are the heart. Making sure those master lists are tidy are the heart of the work we have over the next few weeks. And again, just making sure everyone understands how to access them. We highlight this every single meeting, but for right now, it's even more important. Next slide. And what is end-to-end review about? So end-to-end review is really the refinement period of our work. So it's a time to step back and consider the whole set and ask questions. Are there missing concepts across our four core activities, our activities of standardized assessment instruments, diagnoses or social risks that matter, goals and interventions? Are there incorrect concepts that need to be changed? And are there concepts that are unnecessary and should be removed? We do a fair bit of that too. Um, oh, Lucy, that's a good question. So I would say it is very common for folks to say we missed things farther downstream. It's rare for folks to say we missed things at the end of our work. So sometimes we find, like for instance, we just found an instrument related to our work on racism in the spring that we found in looking for instruments to support these domains, and we're socializing it back with our subject matter experts. So that happens. Usually it's us as a collective finding things, but it doesn't happen very often, but it necessarily happens over time because we are not always addressing food access. So as we move on, we have implementers who submit requests for enhancements to us on a regular basis, and we bring them back to the collective. I hope that was a good answer. But we're always out there gleaning, right? Looking for things. And when we find concepts or programs or instruments that relate to things we've done before, we elevate them back in our own work as well. The difference, good question, Lucy, per usual. The difference between end-to-end review and the time prior is we really want, from a change control perspective, we need all comments and edits to be offered in a written form with rationale and evidence for alternate approaches, right? So early before end-to-end review, we have lots of stimulating conversation in here, and there's lots of what ifs this, and we'll try that, and we'll take it back. But because of the efforts that has been put in to date, from now on, it's emails with rationales and evidence, usually like papers or some kinds of citations, some kind of justification for an alternate approach. This is less necessary when something's missing, even though we still need references for anything that's missing. So this is reference time where we start to gather the evidence to support every single concept you want. But just know from now on, what we say in here is suggestive. If anyone recommends something that's not here, you'll hear me say, please send an email with rationale and evidence to gravityproject@hl7.org, because we have to follow that process. And it's just from a change control perspective to maintain the quality of the work that we do. Everything that you all mention, it happens in these meetings, gets sent up through our subject matter experts and then back to you, right? And this is why we take three cycles of meetings to do it. You can submit comments at any time. So you don't have to submit them related to a meeting. You can reflect and look at the masters next week and send in emails and comments from yourself or your constituents. That's totally fine. But just know we need it in writing with rationale and evidence. And just know that we're seeking input too. Like, we're doing outreach to community health leaders to try to figure out that we get that community health, public health perspective in some of our interventions. So end-to-end review comments are coming from all purposes, but all edits are formal in nature. Any questions on this? Okay. Go team. All right, next slide. All right. I already asked any questions. I'm assuming there's not. I see nothing in the chat. Okay. All right. Here we go. Thank you so much for being here, everybody. Next slide. All right, we're going to go into neighborhood safety. Usually, I'm just going to open the mic for anyone on the team who's with me to comment here. Usually Asha and I do a trade-off with instruments. She's going to read the list, but for purposes of brevity, we have less on the instrument side today than usual across each of our domains, all because we started there. So you guys have seen that content for some time. Next slide. This is a new one. Next slide. So Asha is going to lead us through this. Asha, will you walk us through the updates to NIJ, measures of community perceptions?
Certainly. Happy Thursday, everyone. So we finally have the full panel. Our SMEs have agreed that all of the questions from the NIJ are relevant in this domain, given that one of our problem statements is trust in law enforcement. And so what's new this time around is the question, police in my neighborhood treat people with dignity and respect, and the police department is responsive to community concerns. And you can see the answer concepts there for those questions. And our SMEs agreed that this panel was important when we're talking about trust in law enforcement. And there are some more screening assessments coming, and we will share with you on our next time together for neighborhood safety.
Thank you. And we do have one, can we just go back? There's one perceptions of neighborhood safety concept on there as well, right? So this instrument does two, there's three core metrics we've been talking about with neighborhood safety are perceptions of safety in your neighborhood, of course, trust in law enforcement and non-fatal injury rates, right? So this covers two of them really well. And it's like one of the best in class perceptions of safety, walking in neighborhood concepts that we saw. More to come, specifically on perceptions of safety, as Asha is saying, because of your guidance. And we'll talk more about that in a second. Next slide. Okay, next, diagnostic concepts. Okay, next slide. So here are those existing concepts that we had for the risks identified. Again, we have those three core ones: perceived neighborhood safety, feeling unsafe to walk in a neighborhood at night, feeling there's a lack of trust in local law enforcement, and the high rate of non-fatal injuries. We know that the high rate of non-fatal injuries will be an aggregate concept in our community level domains. We talk about things that are measured at the point of the person and things that are measured at the point of the either the census tract or the census block grant or the county. There's all kinds of different ways of measuring the aggregate non-fatal injury rates, but the data will come from ED discharges the same way the CDC WISCARS data does. We're just working on methods of aggregating that and figuring, and that's why we're reaching out to community health leaders to figure out what that will be. But that one is, the kind of the naming of the diagnostic concept that matters. And yes, Lucy.
Yeah, Sarah, in terms of high rate of non-fatal injuries, this
Mhm.
is independent of source of injuries. I tripped on the sidewalk
Correct.
or somebody shot me but didn't kill me. Does it go basically from all of that to, I guess I'm not clear. If I were a health department and I was interested in high rate of non-fatal injuries in my county, it seems to me I would want to know etiology. So where does this come from and how has it been used in the past and how useful is it?
So we talked about it a while ago. So this is one of the CDC core surveillance metrics on safety in community that it monitors through its national surveillance databases. This particular
Oh,
metric has a set of diagnostic concepts that are related to ED diagnoses at discharge. Um, the etiology is interesting because usually injury codes have some kind of causality. I mean, we have ICD experts here as well. But the reason why this was chosen was because when there was the technical experts gathered to understand the metrics for community safety that mattered, cities and municipalities identified this one, the CDC approach, along with perceptions of neighborhood safety and trust in law enforcement as the three most actionable metrics they could identify to actually intervene on the concern at hand. So it's a standardized approach with a standardized data set. But we can't use the national instrument, the national rate, because it's not actionable with the community. So we just need to drill it down to the community level. Is that helpful?
Yeah. Yeah, it is helpful to know that it comes from such an authoritative source. And I guess all other questions would be answered by going to the bookshelf that has, has been produced by this particular metric to see how it's reported and how it's acted on. Thank you.
Okay. And hello, welcome.
Hi, my name is Owen. I used to work for the Department of Health, State
Love it.
Health Department. Quick
Fantastic.
question. Thank you. Sorry for I just this is my first time. I'm very passionate about the topic that you are working. But my question is, in terms of how organizations can use these in terms to enable or not enable people to activities or walking or feel less stress. I like the what you have, but also it's hard to measure whether it feels safe, unsafe, or safe at 8 p.m. or 10 p.m. because when
Mm,
they say at 9, I assuming usually you grab well at 9 is dangerous, but maybe at 7 to 9 is less dangerous and
mm,
will help me to understand that element will help the person to walk or not walk. That's the goal, right? The enjoy your neighborhood, to do exercise, to socialize, to be in contact with the community. But there are written more as a negative factors and know the potential positive factor they may have. Maybe 6 to 7 everyone is walking with the dog, maybe, right? So that's the time. And help me to understand also to see if this element is determinant or help to the person be healthy and walking because it's safe or unsafe, or it maybe it's safe but it's not walking. So what else I need to find out in the rest of the assessment? That's just my comment. Thank you.
I love it. So that kind of relates to a concept that the community helped us identify was missing last meeting, which is it's also important to understand safety walking during the day. And it relates to the work that we're doing in access to green space, which is why we coupled neighborhood safety with access to green space to describe walkability, environment, and safety for navigating exercise spaces. So your fingers, just for a guy who just joined, your fingers right in the pulse. And there's more, hopefully there's data, you're going to see data bloom, concepts bloom over the next slides that support your observation. Yay, thank you. All right, next slide. Um, so I think actually there's a repetition here. So my apologies. So we have this is the new concept is that feels unsafe to walk in the neighborhood during the day, like we were just mentioning, right? So not just night, right? And then that relates to some, that I think it was actually Lucy who you last time raised this as an important concern, to not just have the nighttime concepts. And sorry if I'm calling you in and it wasn't you. If I feel like it was you, maybe. And then we have a few new emerging community level concepts because again, we have diagnoses or perceptions or risks that are measured at the point of the person. Like, do you feel unsafe to walk in your neighborhood? Do you feel there's a lack of trust in law enforcement? And then we have these aggregate community level concepts. So when we thought about those three base concepts from the BCHC paper, the lack of trust in law enforcement, the non-fatal injury rates, and the perceptions of safety, we realized that there was some opportunity to enhance those with some community level risk factors that drive neighborhood safety as well. And it kind of relates to how we thought about structural drivers in our previous domains, right? So what we know from the literature is there are drivers that affect neighborhood safety and perceptions of safety. And so we're trying to develop these associated with the literature. We know lack of social cohesion affects neighborhood safety. We know economic insecurity affects, John, I really want to hear what you're saying there so I can understand. We know economic insecurity and lack of wealth affects perceptions affects neighborhood safety. And now you hear me catching on perceptions because the economic insecurity does not just affect the perception of neighborhood safety concept. There's actually statistics and evidence that shows it affects possibly each of our three metrics, right? Perceptions of neighborhood safety, non-fatal injury rates, and trust in law enforcement. We know disinvestment in communities affects neighborhood safety. And then our last one that our SMEs are raising is how unsafe built environments affect neighborhood safety as well. Lucy, that kind of relates to the different diagnoses that go into the non-fatal injury rates, right? Because neighborhood safety is also, do I feel safe to walk around? Am I going to trip on the sidewalk, as you were saying, right? Because that's a non-fatal injury rate as well. Jonathan, do you want to raise your question here? I don't quite understand, but I'd love to.
So I guess I'm just trying to be clear on, we talk about the individual and the community level, but like, how do we bridge those two, right? So like an individual is not necessarily going to have access to this, and a service provider is going to have access to it, but not being able to use it meaningfully. So who is intended to use this? And I know I've asked this before. I just want to make sure I'm clear.
Who's intended to use what?
The terminology and the taxonomy. Who's the work that we're doing here? Who's the end user who's going to be using this information?
Well, in the simplest sense, we design terminology for the purposes of patient care, right?
Okay.
So we were actually just walking through this in our SME meetings a few minutes, like just an hour ago, right? So let's say let me tell a patient story, for example, and anyone can chime in here. Let's say we are doing an initial screener with the NIJ and a patient says they don't feel safe to walk alone at night, right? And then I want to do further investigation to understand why, because that's not enough for me, right? I want to understand why they don't feel safe to walk alone in their neighborhood at night. I'm talking, do they feel unsafe to walk, but what else is going on? And they say, they can then, again, not necessarily instruments to support this, but conceptual. I'm listening to my patient and they're telling me that they don't feel like they feel like they belong or are connected to their neighbors. And so when they're walking out at night, they feel like there's no sense of like social connection or social safety. And I was like, oh, so you feel like the lack of social cohesion is affecting your perception of neighborhood safety. And they're like, yeah. I'm like, okay. And then I know what to do with that, right? I know how to intervene. I know what to connect them to. I know how to help. I'm like, okay, so these are the affinity groups. This is the mothers group. This is the parent group. This is the polka class. This is the the water yoga program, right? So developing connections and social cohesions, social cohesion. So what we realized when we thought about those three original concepts, and again, if any neighborhood safety SME is on here, is it wasn't enough to actually develop interventions and tell the whole story. So we're trying to develop these other concepts so we can do that. Let's say unsafe built environments is the concept, right? That's affecting neighborhood safety. As a health system, again, related to what our guest from California was saying, I might decide that I need to invest in improving the walkability and safety of my environment so I can get my patients and clients out walking more, right? Because the built environment that's around them is not safe enough. They don't feel safe, but I have physical activity goals for them. So at least the clinical setting is able to use these, and then hopefully municipalities and communities can use them as well as pings to develop policy changes and investments in the local infrastructure as municipalities do in planning. I hope that was a good answer, Lucy. That's what happens in Burlington, at least in my little city. Lucy?
Yeah, Jonathan, you're probably aware that the California Endowment invested multi-millions in half a dozen communities in California beginning in 2010 to improve their health. And one of the things I remember that was kind of, at least for me, unexpected was there was one community in the Central Valley that identified lack of traffic lights as interfering or creating apprehension that prevented people from walking around. So one of the accomplishments as a result of that grant was installation of traffic lights so that people could get from A to B without having to deal with speeding cars that never stopped. So when I look at disinvestment and unsafe built environments, I immediately thought about traffic control. And certainly today, there's constant dialogue, to put it politely, between drivers, pedestrians, and bicyclists about what is the best safe design for streets so we can all use them. And there's absolutely no agreement about that. But if there were data classified as disinvestment and unsafe built environments, I would certainly see community groups being able to, hopefully being exposed to that type of data. I have no idea how, maybe through a foundation grant, but somehow, and then deciding whether they could fix it or whether the local board of soups has to do something.
Well, actually, Lucy, there really are lovely instruments like Asha and I were just talking about the CDC Built Environment Toolkit earlier today that actually assess just those things, right? As actionable public health, community collaborative interventions and assessments of what needs to happen from like a traffic pattern perspective, right? So these are very squarely in the public health and clinical health arena, as you're noting, and there are that's what Asha was partly saying regarding us bringing in instruments that we haven't that we've seen before and we might need to bring back again. You're raising a very good use case of why we should, at least in my assessment. Any other questions here?
I hope that gives a hint, Jonathan, of how these data might be used. There are really potentially many channels to distribute such data and think about them.
No, that part I get. I think that I'm going back to the last meeting where Kwesi and I were kind of a little bit confused because we were using really high level concepts to describe very specific things that could be niched down. And one of the things that I struggle with is that, like, you know, when everything's important, nothing is important. But for me to contextualize it, understanding who the end user is and who's designed to use it for what purpose kind of helps. Because here in California, one of the things that we struggle with the data exchange framework is a lot of people are just like, I don't necessarily know where to start, or I'm not clear on what it is that I'm being asked to do or why I'm being asked to do it. And part of that is just being able to educate them to point them in the right direction to say, okay, so if you're in Sacramento, or Lucy, if we take your instance as an example, and we say there are incidents of people not feeling safe at this intersection because of traffic fatalities, we need to be able to actually have the data to support making an investment to actually address that problem. And so that's kind of, Sarah, that's kind of where I'm a little bit confused on why I said last meeting that there are different levels, and maybe at some point in time, not to put more work on anybody's plate or put 5 pounds of hay in a 3-pound bag, but at some point in time, making it so implicitly clear that if I am a provider, that I look at this and I'm like, this is what's intended for me, right? And then if I am a patient and I get a cheat sheet and I'm like, oh, so this is why they're asking me these questions when I'm being screened or when I'm being assessed, so that when I go back to my community and now all of a sudden I see that they put a traffic light in, I feel seen, I feel heard, I feel represented, and I understand where my data is being used. And so I don't mean to hijack the conversation, but I just want to make sure that we're being clear with all the different levels of information, that if we could have call outs for who it's intended for, I think it's going to make it a lot easier for people to walk to it and say, that right there is what I need. And I'll stop there, Sarah. I sidetracked this. I tried to be quiet, but I apologize.
No, you're never sidetracking. It's important. I just am a little bit because it's important for all of us. I'm just trying to understand a little bit because, like, I think it's important at each of the levels. The diagnoses we're talking about. It's important at the personal level. This is my story. It's important at the clinical and health systems level for understanding effects on health outcomes. As I'm forgetting your name. I'm calling you our guest from California, even though we have many guests from California, right? And it's important at the municipal level for planning and policy, right? So I think we'll try to figure out how to do that more astutely, but I don't think we're actually thinking about these things as not being important from every level. Our action and responsibility to them might be different, but as information that tell context and help understanding the patient story in front of you and the story of the community that we're caring for, they're important at every degree.
Sarah, I don't disagree with anything you're saying. I just feel like that people are like, what's in it for me? And so they start with where do I need to start considering this at to educate myself, and then they expand from there. So I just am again, I don't mean to sidetrack the conversation. I
No,
just want to
that's
I just want to be clear that when we're talking about these concepts at a very high level, if we have a clear understanding of who they're designed to impact immediately, obviously we want the whole person care aspect of it. But I think that understanding like who's designed to consume what part of the information so that they can contextualize it and use it will actually accelerate how you inform doing the work going forward. And I will stop there.
Thank you, Jonathan. Please.
Okay, my suggestion is we did a little bit of work about this. And the way how we did was we have representative in every county health department who were trained and designed the plans. We used to call health equity plans, in where they take the center, the social determinants of health, and we look at it from the personal and the community level. So the idea, the problem that I see repeated in the work that I did and right here is when somebody is collecting this data, don't have the time or the thought or the vision how the person who hold the information will be extremely responsible to canalize and congregate people. But in order to congregate people, you have to have some capacity building and a small, medium, and large, in terms to, sometimes you don't have anything, any organized, anything. But if in the implementation or the documents that you have, because this is just the diagnosis and things, but in the implementation should call about how you implement this and suggest couple models or couple ideas how been done in different places. In that way, the person who get this being asked this question doesn't feel like it's an empty questions, like and also is not address the solutions, and in some point maybe 1 or 3 years. And the people who I work with, I say to them, I don't have money to create a place to play kids. Sometimes they want that. They feel it's more safe. They feel the community, they can enjoy more when they have a place to the kids can play. So I say, well, you need to get other partners, not in healthcare, because sometimes healthcare is not, but other partners, foundation or other partners who can you come together and maybe have this and apply for grants to build this playground. Because take time, those things, but this is the hard part. Somebody who hold information and they say somebody will address that. That's the hard part, and I know it's very complex. Thank you.
Thank you. And I think what I want to state is that what we do at Gravity is we build the language to name those models and interventions and toolkits that are already happening, right? So our job at Gravity, our job collectively is not to create the toolkit, it's to support the language in the toolkit, right? So you'll see this. So the terms we are creating together, led by our experts, are driven by evidence-based community interventions. They just didn't have terms to support them before, right? And this is bleeding edge stuff, and we get that when we're moving to community level domains. We have to do it by design because we can't be accountable just to person level problems because we work from structural perspectives, right? If we're only ever addressing household food insecurity and never addressing community food access, then we're not actually addressing root causes. But underneath all these terms are like public health models and evidence-based models and community action kits and toolkits and methods and practices. And our job, we were talking about data visibility at a conference in Montreal last weekend. Our job is to name those things that people are doing and to hopefully support what's happening. But it is tricky because it is very aspirational, and we do know that. And the implementation is the sticky part. Luckily, our experts are experts in implementation, so we can just be namers. We're going to keep going, but thank you for the accountability. And we do want to make sure this is end-to-end review. We do want to make sure these concepts represent best practice, and they represent what we know actually works, and they represent terminology that's meaningful across the different perspective, whether it's be it from the patient perspective, this tells my story, the clinical perspective that I know what to do with this, or from the community level policy perspective as well. Next slide. Okay. Okay, we're on to goals, I think. Okay. I think Lucy, I'm going to try to read what you, so Lucy's giving, Lucy, okay. Yeah, and it's also, Lucy, shared language between public health and health records, right? So that's part of what we do with Gravity as well, is make sure that we're borrowing public health and CDC approaches and language as we name clinical concepts. Next slide. Go team. All right, so goals. This is a work in progress, but we always work from a strengths-based perspective and work towards goals. And one of the things that we identified in our work here and everywhere is specifically with community interventions. If we remember the vital conditions framework and we remember all of our strengths-based models for community engagement, in the face of identifying the risk, the best way to address the risk is to work toward the goal. Right? And so one of the things that our subject matter experts have been doing is curating goals that they know actually move the dial on those community safety metrics. This is a partial list, it's a work in progress. But we have these concepts in just institutions and just systems. We talked about social cohesion being a risk, so social connectedness is a goal. Community connectedness, that came from our protective factors work. We know about the critical nature of engaging youth in schools and a sense of school belonging, so that's there. We also know about the critical nature of engaging youth in extracurricular activities. You can see a whole bunch of the CDC concepts below: safe, stable, nurturing relationships and environments. Those are directly relevant to this work as goals to work for as we address perceptions of safety. We see safe green space. So all of these goals are the goals. If we've identified our risks, it's the where we're heading. Because from the literature perspective, you can't actually achieve the where you want to be if you just work on addressing the risk metrics themselves. You have to think about the future state. And again, for anybody who wants to go back and read the Vital Conditions Framework or the Equitable Plan for Long-Term Recovery and Resistance, that was a cross-federal agency piece of work that was based on the Vital Conditions Framework. That's a lovely piece of literature to find and look at. All right, next slide. So one of the things we want to address as a gap is that you can see I hearkened it, and our friend again from California brought it up, and Lucy was talking about it with sidewalks as well. Is we have the National Institute of Justice instrument. We are based on all of your input going to be circling back and looking at additional assessment instruments. And these specifically ones that we want to figure out, those ones that community use to assess the community itself. So not just perceptions, but actually community assessment instruments. And that's where the CDC Built Environment and Assessment Instrument comes in. You'll see mirrors of this across our other domains as well. And then there were some concepts in the multi-ethnic study of atherosclerosis Mason neighborhood questionnaire that might relate to our perceptions of neighborhood safety elements as well. And then we are still working on developing actionable goals and intervention terminology. So we just spent most of our day today looking at the evidence-based interventions aligned with CDC, public health, and national literature that actually work to address risks, and looking through all of our past terminology to support those interventions. So more coming there. We're working really through a couple really critical national frameworks for addressing goals of community safety there. And if you have any specific paper that you want to send that you feel like this intervention, as evidenced by this paper, needs to be in the master list, please send us an email at gravityproject@8till7.org, and we'll be sure to have it evaluated with the SMEs. And then do SMEs talk about power? Lucy, I think there might be a typo there about power at purse. Lucy, what did you want to say there? Personal level. Oh, we talk about both agency, like individual agency and collective agency and impact. It actually relates back to Lucy. I don't know if you remember the belonging and civic muscle concept from Vital Conditions that we talked about so much in protective factors. We're bringing that back again because when we think about, again, Jonathan's question of who's going to intervene, the clinical system, or like policy-wise, We want to make sure people see themselves in individual interventions. We ensure we have clinical level interventions, and we ensure that we have community level interventions. And that's where that civic muscle comes in, right? It's like agency. Like, and you'll see a lot in our access to green space domain. We have a whole host of just things that people just can go out and do. They don't have to wait for anyone to do anything, right? And so, yes, that should be coming back soon, shortly. Okay, deep breath. Breathing. Okay, I think this is our neighborhood safety domain. Again, it's end-to-end review. If there's things you think are missing, if there's interventions you think are missing, if there's risk you think are missing, goals, instruments, send them to us in an email, gravityproject@hl7.org. But no, specifically from the interventions that we are working on analyzing these massive national models with evidence-based interventions, and those should be in the master list by the time we come back next time. Next slide. Next slide. Food access. Sometimes we retire slides because we've seen them too much. We're not doing that this time because this is so lovely. Dr. Usher's beautiful model on food access, with aspects of acceptability, accessibility, accommodation, affordability, and availability. So we were just talking about neighborhood safety, and we're now going into food access. And I mentioned, and I was talking about with Jonathan, that we, as an accountable, like we work from the World Health Organization conceptual framework for action on the social determinants of health. We can't just stay in the effects and experiences in the household. We have to talk about community level drivers. This is why we're doing this whole domain. And so this domain specifically is about food access in the neighborhood, and individual person level perceptions and community level perceptions that matter. Next slide. Great. Next slide. Instruments. Asha, do you want to take this?
Yeah.
Yeah.
All right. So Sarah just detailed all of those dimensions of food access. And so the standardized instruments that we have do a really good job of getting to all of those different dimensions. We have the Medical Expenditure Panel Survey, MEPS, the social and health experiences. We've got the neighborhood scale, availability of healthy foods. We've got the fruit and vegetable community assessment tool that has come to us from CalAIM in California. A very good tool to assess accessibility and availability and quality of fruit and vegetable access in the community. And then finally, we have the Perceived Nutrition Environment Food Environment Survey. And all of these versions are available on the subject matter expert approved assessment instrument, which can be found on the master file available for your review when you're ready.
Go
All
team.
Mhm.
We do have so many concepts. We have to trim the slides at some point. I think we had 80 slides, and we still we have
Yeah.
so much to do. Okay, next slide. So this is a very, very simple slide of a slide that used to be very robust. We are drawing many of our metrics from the USDA Food Access Research Atlas. Again, all those details are available on the master file and the Confluence. They have not changed. We have gotten some community comments and end-to-end review asking us to look at different metrics in the USDA Food Access Research Atlas other than just low access. That was a very lovely comment. Thank you, friend out there, who I will not name. So maybe you might see additional data elements within the USDA Food Access Research Atlas, but the USDA Food Access Research Atlas remains a core data source of reference. Next slide. Next slide. All right. So this hasn't changed too much. But the one thing I want to note is that I want to personally accept responsibility for using unclear terminology. So, Jonathan, this relates to you. So we realized that we have used the word community to talk about social connection and belonging in prior domains. And in these domains specifically, we are literally talking about built environment. It is the set of concepts that these relate to. access to green space is a built environment concept. So is food access, and so is neighborhood safety related to, well, partially, right? So we are changing our tack, and we are not using community in our concepts because we wanted to create a consistent concept that was relevant across all of our different domains. And we are using neighborhood because neighborhood is the most relevant concept now. We will possibly change it in time, but we moved away from community because of the social emotional complexity and because we've used it in other ways and in other definitions. And so we're not using it here now. We'll figure it out as we go on, but for right now, it's neighborhood. Again, most of the metrics that we're looking at are about where I live, right? We even thought about where I live, but then we just went back to neighborhood. Hello, yes.
Just in a small note, because when we work with rural communities and I
All
work,
neighborhood.
they say, if I say, oh, you go to the neighborhood supermarket, I say, well, no, they call me my name. We go to this place, which is another county. Say, just a consideration for rural and
Mm,
like a note or something, because you
mm.
don't mean to to make feel people bad. I
Yeah,
think
I'm a rural
that's
girl.
I like in neighborhood, yes. But as for rural and for urban and suburban, but rural sometimes they have to shop in another county or in another
Love it.
places. But just in a small note to
That's a
comment.
great
Yeah.
note. So maybe where I live is, we'll take that back to the SMEs. That's really insightful. I mean, I literally live in like near wilderness area in the northern Vermont. So noted and heard. The dairy farmers I take care of do not use the word neighborhood. Like, at
Sarah,
all.
that's where we got derailed because Questy and I were like, when we say community, what do we mean?
Why no? So we're changing it to we're going to be anchored in built environment concepts. We just talked about where I live being one of the options, and then we settled on neighborhood. We're not doing community because we felt like that was too vague. We're getting there. We're honing end-to-end review, refinement.
So if it makes you feel better, there's a lot of people that create solutions looking for a problem. There's actually a problem that we're solving. We just need to make sure that we're connecting the dots for the right people to make it as easy for them as humanly possible to utilize.
That's not love it. And it's like, hi Joe. It's good to see you, Joe. Area, I like that. Thank you. And again, I know I said formal comments. We're having a collective brain think here. Like, Joe, it's good to see you again. I know you're a comment guy, not a take yourself off and speak guy, but I really appreciate it. Again, I was a Montana farmer before I became a Vermont clinician, so deep frontier level conversations are important. We do actually have some frontier, deeply uh, deeply frontier perspectives in our subject matter experts, and so we'll vet this with them. Thank you so much. We're getting there. Thank you for the Wyoming perspective. Great, love it. Okay, next slide. Where I live, I know. Yes, I know. I kind of keep on going back to that. I kind of like it's a very salient thing. We might come back to that as well. Thank you, Lucy. And so you can just see we applied this. This is just applying and removing the word community and evolving it. And again, some kind of built-in environment, like physical location term is what we'll settle on. We'll bring all your brilliant thoughts back to the SMEs. No, there's no change in the concept here, just in the neighborhood, we're moving from community element. All right, next slide. I don't think these are existing, so I'm not reading through them because if they just change the word neighborhood, again, every single concept's available on the master for you to download on Tuesday at 5 p.m. Pacific time. So please do that. And then there's no changes on here. These are steady since our last assessment. And so you can see we have our concepts associated with Usher's model. Just to make sure we're following the lit, because that's what we do. Next slide. Oh, hello. Yes.
My last comment. For me, food has been really very important topic, and I think you capture really well in all these concept. But it's one area that bothered me so much in my work ever is when you see people going and get those assessments about social determinants of health, right? And there are moments where the person could maybe like top some kind of food. For example, if I'm very hungry,
Yeah.
sometimes I could eat a lot of pasta, right? Or I get used to eat a lot of chips. And I maybe I have access to fruit and vegetable. I have access to those things. But when we analyze the needs of the community, even though they could have or not access to good food and vegetable, is the way how you were grow up on
Oh,
situations.
yeah.
And so it's hard to measure that part about me because I see some interviews, and with clients, I'm observer, and I see how then I ask the question, I say, how is your glucose? 400. And
Mhm.
I say, but I thought you have access to food. They say, well, I like to eat a lot of this. So the goal of the addressing social determinant, which is improve health outcomes, get uh, not successful as we want. So, but that part is it bothered me over in the back of my brain. But that's my comment. Thank you.
No, I love it. Yeah, it's a very important. So what we're talking about from this SDOH perspective is the barrier, right? Is there a barrier economically? Is there a barrier in your where you live? Right. And you're very right. But that's not the whole story because then you have to think about behaviors and choices and cultures and patterns, right? And we have to think about systemic forces in those, like like food swamps. We're going to be talking about that. Right. So 100%. So we addressed food insecurity in 2019. We're addressing the access to food in your neighborhood. And there's a whole other realm that could be addressed regarding the actual choices that we make within once this barrier and this barrier are addressed. Noted.
And
Love it.
and the last point about connected to that, I'm sorry taking so much time, is what I love about this is there could be a place where organizations who work together, hospital, insurance,
Mhm,
healthcare system, community-based organization, churches, will have a platform of data.
mhm,
And because the ideal situation, because when we talk about best practices, we don't have all the best practices. We are
mhm,
not solving the problem yet.
mhm,
We are organized, we have a lot of best practices, but it doesn't mean that we have all of them. And
mhm,
one area that is hard for me in terms to best practices is the research part, why
yeah.
people make decisions. We don't understand well the process of thinking. The people make decisions when they eat, when they exercise, when they're thinking to do things, and that could be these early stages to make this comment, the data, the point, the dimensions, the concepts. They will enable research people to think about future research projects to understand a little bit more, understand deeper barriers that we are not there yet because we
Yeah.
don't have a common data to do that. So that's just a note.
I love it. Like maybe in the future, every single person who lives in a food swamp gets a produce prescription. Why not? That sounds great. Yeah, I hear you. There's lots of research capacities, and that's partly why we create the terminology, is we create the evidence-based thing, and then it enables all kinds of future use cases and purposes, including research and population health. Good team. Okay, next slide. We're doing it. Interventions. Oh, here we go. Interventions. We were just talking about this. Next slide. We have some things that are new and they're on this slide. This is a very sweet little slide. Definitions are coming. We have a whole bunch of US definitions. I want to applaud the amazing folks I work with because we found a ton of US definitions. We try when we can to use international definitions because we built an international terminologies and we create the best standard when it's at the highest level. So we have US references for every single one of these things. We are not using them right now because we're trying to find the international correlate to create the international concept. So we have mobile food markets, community gardens. We had a garden program before. We're going to try to figure out if this is duplicative or not. We have food co-ops, which one of our frontier specialists is a food co-op specialist. What's the best way to solve, so Joe, the Wyoming story, what's the best way to solve neighborhood food access concerns in, on a reservation in the northeast corner of Montana, build a food co-op, right? That's what we did in Montana in my tiny rural community when I lived there. Farmers market programs, that's an identified need because we had specific farmers market programs, but we didn't have a general concept. Community markets, that's a work in progress concept because we came up with all kinds of ways they could solve their their market problem. Municipal markets, nonprofit markets, FQHC markets. We don't want to build a proliferation of different types of markets that are not retail driven. So we're trying to figure out that, like how to name that. If anyone has any ideas, please let us know. Community is where we're settling right now. We came up with community-supported agriculture prescriptions. We didn't have that in our terminology before. That happens extensively. I think everyone, my favorite thing about summer in Vermont is every single person on my panel who has a chronic condition of a certain sort, diabetes, hypertension, heart failure, or dyslipidemia. I can set them up with a free CSA program and like nutrition classes. It's amazing. And then we talked about edible landscapes. And so, Jonathan, this is one of those I can do it things, right? Edible landscapes can happen at the municipal level where you build food forests really intentionally in open public spaces. They can also just happen in like rogue blueberry planting and an unused spot in your neighborhood, where you live. So edible landscaping, and again, that's an international concept and more. Yes, exactly. Hospital markets, those happen too. 100%. Great. 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 Oh, Jonathan, I just read your comment. That's lovely. Okay. So definitions to come because all of these we have US concepts for, but we want to make sure we're thinking international. Next slide.
I have
Oh, yeah. Go for it.
I have one more for the list that you have.
Okay, so this time, because we're when it's new, I'm going to ask you to submit. No, please. Don't please name it and send an email. Just from a
Okay,
tracking perspective.
what about
Yeah.
the supermarkets where supermarket could have better, more organic or better food for the community too? Like I talk to
I hear
Costco. I
you.
say, Costco, can you bring
Advocacy.
this?
Yeah.
It's just what I like about the supermarket as an intervention is because you can return it, and sometimes it's better prices for the fruit, some of the fruit items, fruit and vegetable items, and you can return it. So it's no more expensive sometimes. Some of those areas that are more expensive than the supermarket when they go. So do you know
Correct.
who is buying those more
Yeah.
expensive? Why they don't go to this? Well, maybe they don't have access, right? But
We
I
do
think
have in the hopper, sir, you're so astute on this, programs related to the kind of work the USDA does through the Healthy Food Financing Initiative, which is a long sentence, which is incentives for retail entities to invest in under-resourced food access communities, right? So we do have that like a true like normal food market. We just have trying to figure out the wording because Healthy Food Financing Initiative is a USDA specific program. It's lovely. And the grants, October 10th was the last day of the last grant cycle. So the new funded entities are coming soon, but right on. We have that too. We just don't know what we're naming it. That's why it's not here yet. But very good noted. It's like incentives for retail locations to invest in neighborhoods. That's a long statement. Retail healthy food incentives. That's lovely, Lucy. And again, if you can do emails, we like them. We are trying to capture things. I see Asha writing furiously. I see you. I see you. All right, next slide. I'm just trying to get through all the slides. All right, this is a dump, right? It's a dump for this reason. All of these come from our existing work on food insecurity. And we had a long conversation over multiple weeks with our subject matter experts as well, whether concepts within the emergency food system and food assistance programs should come into the food access domain. And we decided they decided for now, yes. And this is the reason why. Given the intersection of food insecurity and food access, the fact that often emergency food assistance is the only way to immediately increase food access in neighborhoods, and given the role of food prescriptions in addressing food access concerns, so it was like a this, and this. SMEs brought in a bulk set of existing food insecurity concepts into the neighborhood food access domain. These all exist. These all have definitions. These all have codes. we don't have to debate them, right? Sometimes our SMEs are so smart, they're helping us look at definitions that we had in 2019, because this is one of our first domains. But their assessment was sometimes the emergency food system is all a neighborhood has when they're trying to access produce because of the way produce comes into food banks through the commodity food program, right, or through special programs. And so for that purposes, they brought them over. Certainly, again, it doesn't address the root problem, but it's a first level solution. Root problem is get everyone able to afford affordable markets in their home communities, right? But this set of information came over from food insecurity for that purpose. I hope that makes sense, right? It's not wrong, was what they basically said. And if it's the first level thing a clinician can do is in the absence of getting the bodega to have produce, do a produce prescription. They were like, it's a first step, right? Because certainly not all of these are driven at income drivers. Some of these are actually just access drivers, right? SNAP is an income driver, WIC is an income and nutrition driver. Some of these are truly emergency food system programs like food pantries and FDIPR. But anyway, more to come. Yes?
We use some of these in some of the intervention for maternal and child, and that was amazing because as part of the implementation of the maternal child mortality and morbidity and mortality maternal program, telehealth program, we were able to review some of the steps of these programs and make it better in terms to what do people really like, or why people are not collecting, why people are not eating. And
Okay.
I believe all these programs are great. Some of them need to be evaluated for improvement, like anything
Okay.
else, but
Yeah.
that's all.
Wonderful. Fantastic. And so we know specifically in the perinatal area age, like in Asha, I mean, I bow to you in your expertise, right? Because of the evidence in intervening in the perinatal period, specifically with nutrition and housing programs, like waivers sometimes just focus on that population, right? It's like it doesn't matter if you're income eligible, doesn't matter if this. If you're in the perinatal period and you want specialized foods box, you get it, right? So beyond WIC eligibility, beyond anything, it just is such an anchoring and important thing. So thank you for that little story. All right, I think we're good. We're gonna keep on trying to go on. It was a big new concept dump today. More to come. End-to-end review is like, it just starts blooming, the master list. Next slide. Again, we have similar closing statement when it comes here. So we looked at the USDA Community Food Security Assessment Toolkit early, didn't include it, but now we're kind of going back to it, right? It's a really beautiful instrument built for just this purpose. Like, what are the foods in my neighborhood? Are they affordable? Can I get thrifty food plan in my local market? Is the produce here? What does it cost? Can I buy peanut butter? Can I buy cheese? Can I buy milk? It is a gorgeous community assessment instrument. So we're going to look at it again. And then we're still going to be developing those actionable intervention terminology that's sensitive to neighborhood, clinical, and municipal concepts beyond the set we already have. And again, this is why I'm reaching out to colleagues at things like NACCHO. Like, I really I feel like we need to better understand how public health, community health, and city entities would name the things that they do. We have clinical stuff down. I think we have personal, seed bombing down, right? But we're really going to make sure that we develop those municipal concepts. So if anybody has any thoughts there, I see you nodding. It'd be great to make sure that we name those concepts well. All right, I think we have time to bust through access to green space. Next slide. Whew. Next slide. Next slide. Asha, do you want to briefly cover the green space instruments?
Sure thing, sure thing. So we've got two standardized instruments for access to green space. One that comes from MEPS, again, the social and health experiences, and the other comes from the Adults, People, and Nature Survey for England. And the reason why our subject matter experts thought that was an appropriate standardized screening instrument is because it explores wild spaces, right? It explores blue spaces.
Yay.
And those are green spaces that a lot of communities really, really enjoy. So we wanted to broaden it out and make sure that we included instruments that assessed for those wild spaces as well. And if you would like to review these instruments in depth, again, they are on the subject matter expert approved instrument list, and you're welcome to review them. They are there right now for your review.
I just want to note that after weeks and weeks of me going, and blue spaces, every time Asha presents
Got
the
it.
instrument, she's
Yeah.
like, you don't have to do that this time.
I gotcha.
I'm a water lover, so my nature exposure therapy is always to water if I can get there. Next slide. Next slide. These again have not changed since our last meeting. So we have these again from a community level concept. We try to find community level data metrics that you can imagine a health system understanding the tree equity score of the health service area it serves, or the park serve score, the access to green space score, again from that walkability. Like I'm describing you walkability. Do you have a green space you can connect to? I have this data from park serve that tells me no. So there's work that I need to do. So these have not changed, and they're available on the master file. Next slide. Next slide. So there's some slight changes here. You can see we're continuing to refine our use of the word community. But we're also making sure that we reflect in our concept the measured entity. So in ParkServe and in the Feng et al. Paper and in the tree equity score, it's actually, sorry, the last should be the census block group. My apologies. It's census tract, census block group, right? And I messed up the last row. Because when we build these concepts with SNOMED and terminology, we actually have to name specifically the measured entity and the reference. So we have to be very clear on that. And again, so we're just trying to evolve our terms there. Next slide. Again, those haven't changed otherwise. Lucy, this is my shout out to you. I put in the square feet there. I did. I don't know if it's helpful, but this is the WHO definition of what adequate access to urban green space. Again, we try, part of our mission with the New England, the UK instrument was as well trying to not just think in urban, but also conceptualize rural. But for urban dwellers, this is the WHO concept of what adequate is. And so we felt we'd be remiss if we did not include it. Yes?
A note for the previous slide.
Okay.
I'm talking about Jonathan lenses, when he talk about who is going to use these. I love census tracts. Community do not understand well in general census tract. They understand more neighborhood or zip code.
Yeah.
And so I think there are some websites that try to align the zip code and the census tracts, in that way they can be a conversion, in that way people who, because it's everyone on the table, Gravity Project, universities, healthcare, community, churches. And I think census tract is a really good way to look the data, but also a note in terms to how we explain that to the community who use more zip code or neighborhood, for people who are reading, in that way we really representing different, all the communities.
One of the things I think would be so actually fairly easy to do, and I say easy, and I know this dangerous term, is like a community could have its dashboard of these things very easily apparent. And it's just there. Like this is my Burlington, Vermont's dashboard of its tree equity score and its, and its park serve score and its low access food score. And I know you were like already on it apparently. Yeah.
No, I think you have a beautiful soul, because you think like that. Not all the communities, not all the agencies will do that.
No, I know.
Data is so important because it can show you how good we are with doing, and
But
governments in general don't want it to show
mm,
data whether we are doing not great. So
yeah,
that's
I
the
hear
reason I
you.
say you have a beautiful soul because you are looking that every community should know that.
I
I
agree.
agree with you, but and California have good ones. Massachusetts have good ones. I see couple who, wow, you know, in at maternal child in California, you can see a lot of information, and everyone can see it. But we are not there yet. But I think it's a good path. Thank you.
It's very kind. And Joe, our friend, just had another great example how census block group level, which is that last one, the tree equity, is needed to translate some data from census tract view to voting district or school district, which is talk about policy. Like, thank you, Joe. Yeah, which is important for connecting conditions to decision makers. Joe, thank you. Great. All right, keeping on going here. Whew, so you see the continual refinement of the word community here to neighborhood. Otherwise, these concepts have not changed significantly, except for the last one. We were trying to represent the intersection between access to green space and people feeling like they want to occupy them. And we were recognizing that things like sharps, etc., definitely inhibit use. And it was the primary finding of not feeling safe to utilize a park. We realized we're trying to figure out the right word here. Hazardous feels like toxic waste. That's not what we were intending. Like, we really are thinking about this like biohazardous trash. We're working on this. It's in refinement, but this is our refinement right now because we're really talking about things like discarded condoms and sharps and things that really make parents and people feel like they're not safe to walk and navigate in spaces, as opposed to just not being maintained. You can see that we sunset having trash because we felt like it rolled up into not being maintained, and we are trying not to create a proliferation of terms. And we also crossed out wild spaces because trails in any space being maintained is important, whether it be a park or whether it be in a wild space. And then we also formed the first one. I just realized this one other thing is that we felt like unable to access biodiverse spaces was way too vague because what does that mean? And so we refined it to neighborhood green spaces lack biodiversity, which means it's not easy to access. And we felt like that was a better standpoint because I could get in a van and drive 2 hours and access a wild park, and that could be able to access biodiverse spaces. It doesn't tell the story of my neighborhood. Next slide. All right. Okay, next slide. And then we have, this is just the neighborhood change again. All right. Because we've realized it was not clear that we're talking about our neighborhood. And maybe it's going to be where I live. We don't know. More to come. Next slide. Oh, this is the, I keep on thumbprinting, not intentionally. It's very odd. So this is the Park Serve metric for census tract with above the national average for park access. We're in end-to-end review, so we're starting to talk about whether this is helpful or not. You know, just being above or below the average, is it something a community is going to act on? We're reflecting on that, and you can come and reflect with us. We do like the next metric. It's been present for some time. And because these are our goals, concepts, because that is when you are actually achieving the adequate green space for child well-being. And then we have able to access biodiverse spaces, which is the antithesis of neighborhood lacks biodiverse spaces. So these are our goals. Next slide. I got a little lost in the details there for a second. Yes?
So I agree with you with the previous slide. I think it's a good idea to have a measure to goal, the goal, but also to reach, and
Yeah.
do it better. But also you mentioned before that you try to do internationally. So in my ideal world, will be what is the countries who people use a lot the green space and what is their percentage. So you can put a national and international as your best practices because we are not the best, even though our
Mm,
national could be not the best because we have so many, obesity epidemic. So even though that goal maybe could be good for achieve, but other countries
yeah.
who, who are more better shape, they have a different, maybe, I don't know.
Yeah, so this is where we kind of got caught. Is like, is this the correct? Sorry, I tripped on my words originally. But is this a good goal, or is just if I'm 60, do I want to get to 75? And if I'm 75, do I want to get to 90? Right. So we'll figure out. Thank you, because this goal is a relative concept. And communities should be able to set goals that are important for them wherever they are, if it's continually improving. Okay, whew, we're doing it. So close. Next slide. Lots of talking today, so I'm getting tripped up on my words. Oh, so this is there's a fun set. Recently learned that some types of oh, so thank you, Lucy. We'll take that back. We have some really fun thinkers in our Access to Green Space folks, so we'll take that back. We actually have a very interesting conversations on biodiversity and fire hazards and types of biodiversity that are good and hazardous plants and how that affects access. We've had quite the ranging conversation. But this is our original attempt at access to green space interventions. And in here, you'll see a lot of uh, person level initiatives that are not dependent on the clinic and are not dependent on municipalities, that are simply just going out there and reclaiming and shaping space. So you can see we do have community participatory design here. We're trying to figure out how that is a constant concept across all of our domains this cycle, but we know it's our access to green space folks have said it's important here. We have a similar related to neighborhood safety, community design, a concept in neighborhood safety. We have community-led initiatives, which is vague. We're trying to anchor that. Greenway reclamation, which is a biodiversity and food for edible landscape reclamation that happens all over my city. Community rewilding, reuse of existing space, an example of that being rail to trail. Um, uh, Expanding coverage for nature-focused modalities is a little unclear. We're working on the wording. We're literally talking about expanding insurance coverage for nature-focused modalities. We're trying to figure out how to represent it. It's in the hopper. Community agriculture programs, where we understand that's close to community gardens, and we're trying to figure out if it's duplicative. And then pocket parks, which is one of my favorite things in the world. Just when neighborhoods get together and reclaim spaces that were not occupied before, that are not necessarily on the map as a park, but are places for communities to gather in place. This is just a list, partial list, more to come. There's a lot behind that the access to green space meets haven't released to the wild yet, but these are, again, no pun intended, but there's more to come there. Next slide. More here, we have seed bombing, our biodiversity intervention, wildflowers. I sent pictures to the Access to Green Space SMEs of all the wildflowers I saw in the East Village when I was in New York the other day. I saw like wildflowers blooming everywhere. Food forest was, I think, supposed to be sunset under edible landscapes, I think. So my apologies, that's on me. It should have been crossed out. Protecting and managing urban forests, that's one thing that our SMEs have been talking about, ensuring that existing forests are maintained for longevity and maintained healthily. Tree planting programs, including like community-led Arbor Day programs. These are tree canopy, tree equity related interventions. This one is a work in progress, biodiversity with health benefits, because this relates to some plants not being happy for folks with asthma. We saw garden programs, it was already there, crowdfunding green spaces, community park maintenance, and community beautification. Whew, it's a long list. These are all, again, in the hopper for end-to-end review, and as I say them, I recognize some wording opportunities here. We have references for most of these, and we'll be working on definitions, but this list will probably get narrowed over the course of our next weeks. And some of these things already exist, like garden programs already exist. And again, as I mentioned, food forest was supposed to be sunset under edible landscapes. Next slide. I think we're close. Okay, we are. Asha Manuel, we did it. Sarah Bahal. That was a lot of talking. All right, so we are working here. We have a good set of instruments and access to green space. We have a pretty solid set of risk concepts. Our next thing is to really refine that intervention list. You saw me tripping up on some of the wording there, and refine our goals as well. And then part of that relates to what we use as thresholds and benchmarks for goals to allow communities to identify their own goals and unknown metrics, right? That's really what you were saying there. So that's where we're going to be coming in there. If you have any references that you feel like are supportive of specific interventions, please let us know. Yes, hello.
Sorry for talking today too
No,
much. I didn't talk for a while, so sorry. One of the things that we find out when we work with community is the level of resources, federal, state, and local, right? We always say the locals have the answer, the locals have the community, they understand well, and it's true, right? But imagine three containers, like in the chemistry, and they have three colors. So for every problem, the feds have some resources and understanding. The state has some resources, understanding, and capacity to do things. The local, the same, right? The problem that we have is sometimes the feds think there are divorced from the solution of the locals. They put a line, they provide grants, they provide resources, but they are not really part. It's like a local area is not part of the country where they represent, right? So I think it's very important the communities kind of leading, but they have the state and local in some projects, because there are so many projects, so many local are part of the team, and they are like they own it, and the state can do things and the federal they do things the local do not have, because sometimes local don't have what the fed and the state have in terms of resources and other information. For some reason, sometimes there's a divorce between the feds and state with the local. And the local, like I said, they have the solution, they have, the leaders and all these things, but they need the other parties be part of the solution, like like a marriage, not like that's your problem. I'm here just to listen, and
Yeah.
that doesn't help. And that's my experience with the projects that we did, and they could be better when there were more coordination. Thank you.
Absolutely. Yeah. And I think part of what we identify is sometimes we just need to tell the story and tell the story loudly as communities and consistently to get that marriage to actually happen. Asha, we've been talking about what is the end goal? Like, we're not saying policy is going to change by the presence of this concept, but a story, at least a community will be able to tell its story authentically. And then if you tell it loudly enough, maybe some folks can come and help, or you develop community responses to community-led problems. I just want to note, Joe also brought in another rural perspective. Joe, you are like the rural voice today. I thank you so much. I feel like I'm doing like you're covering us. Thank you for adding that the fact that park is in the literature an urban concept, and we want to make sure that we have risk statements and goal statements and interventions that are not just about parks. That's why we have the UK instrument in there. So thank you so much for bringing that. We'll bring that back to our SMEs, and thank you for coming. If anybody forgot to put their name and where they're from, I want to make sure that I have all of your different allegiances and alliances in here, so we can make sure that we track that. And then next slide, I think we're close to the homework. Everyone should have their homework very clear. I tried to make it very clear. The homework is, oh, we're gonna skip this next time. We're gonna go to the community homework slide because we're at the end. Okay, thank you. On Tuesday at 5 p.m. Pacific Standard Time, the concepts, including the instruments that we mentioned, and the data sources, will be uploaded into the masters. It's end-to-end review. Everyone needs to download those masters, socialize them among your people, analyze opportunities to either add things, refine things, or remove things. Send us emails at gravityproject@hl7.org, and we will